So I'm going to start with the Hip Pelvis. So I have my 14 by 17 IR crosswise in the bucky. I'm going to make sure that I'm collimated. I'm going to leave a little bit of collimation on all sides. Detented, I'm aligned to my bucky. I'm going to feel for the top of the crest. So the top of the crest is the top of the iliac crest is the top of your hip bone. If you put your hands on your hips, that's where your hands will fall. If you do it on one side, patients tend to be a little bit more ticklish. So when you're feeling for the crest, it's a little bit easier to try on both sides. So you're going to take your hands kind of like this, where they're perpendicular to your patient, and feel for their crest on either side. Once you have the level of the crest, then I typically leave my left hand there, and so I know where the crest is the whole time. I'm going to make sure that the top of the crest, my cassette is just a little bit higher than the top of the crest to make sure that I definitely get all of the pelvis on my film. So the top of the crest is here, my cassette is lined up just right about here. So even though the light field, it doesn't look like the crest is going to be in there, I know it is because that beam is going to continue to diverge before it gets to the plate, and so it's definitely on there. So since I moved my bucky, I'm going to make sure that my tube is still aligned. I'm going to make sure I'm at 40 inches. And then I just make sure that I'm to the midline. If you are trying to find the midline on your patient, it is kind of hard to see from the side. So what you can do is go towards their head, and you just kind of look down the center of the body. And I can tell that I'm definitely a little bit off center. You can also ask the patient to point to their belly button, because the belly button's always the midline. So that's your line. There's nothing that you can really palpate in the center of their body to look for a midline. So those are some kind of factors that you can use to find out where the midline is. So this will cover the entire pelvis. The last thing I'm going to do right before I shoot is I'm going to come down to my patient's feet. I'm going to make sure they're separated just about a foot, and then point their toes together. And that's going to make sure that that lesser trochanter is out of the way and the greater trochanter pops out and we can see it. I'm also going to make sure that their hands are above their belly button. That's good. Sometimes if they put their hands right under their hip like this, it'll show up on the bone, so I want to make sure it's not there. And then right marker, I'm going to go ahead and put my marker on the cassette itself. All right, and hold your breath, don't breathe, and you can breathe. So this one is no shielding per department protocol. If your department, you can relax. If your department has shadow shielding or something like that, then you might shield, but for the purpose of lab, you're not going to shield for your pelvis. From the pelvis, I'm going to go into bilateral hips, which is similar to a pelvis, but just centered slightly lower. So now the top of my crest is here, and the ASIS is here. So now I'm going to move my patient so that the top of the film is now at the ASIS. Make sure that I stay centered. I would change out for a new cassette if I was using a CR system, and this one is going to make the center of the field at the actual hip joint. So I still have my marker there, still at 40 inches. All right, and hold your breath, don't breathe. Breathe. That's bilateral hips. You can relax. Now I'm going to go on to unilateral hip. Do you want to do bilateral frog? Oh, thank you. I'm going to go to bilateral frog. So another 14 by 17 crosswise. I'm going to keep my right marker on my cassette. Now what I'm going to have my patient do, so this is the bilateral frog. I'm going to just put these sponges on the side. What I'm going to have you do is bend this right knee and let your leg fall open and rest on the sponge. Very good. I'm going to do the same thing on the other side. If your patient is really limber and they can hold their legs on their own, you don't have to use the sponges, but it makes it a lot more comfortable. Good. And this one is the same. So this is the Cleaves method. We still are aligned and detented. And the top of the field is still at the ASIS. So I definitely have both hips on there. I also have the legs open to a 45-degree angle on each side. And this is going to give us that AP oblique of the hip. All right, 40 inches still. All right, hold your breath, expose, and breathe. All right, so you can go ahead and straighten your legs. So now I'm going to do a unilateral hip. This will be the AP unilateral hip. I'm going to do the right side. I've got my cassette in my bucky, and now I'm going to collimate. I have a 10 by 12 lengthwise. I'm going to collimate down to the area of the cassette and detent. And for this one, we're centering at the femoral neck. The best way for me to find it, and because it's now unilateral, you're expected to shield. So you're going to shield the unaffected side. And the best way to find out where the femoral neck, or one really effective way to find out where the femoral neck is you place your shield from the ASIS to the symphysis. And remember, the symphysis is a bony landmark that we're not going to feel, but we can see it. And from this line, you're going to find the midpoint, and you're going to go 2 inches distal to that. That is the location of the femoral neck. You can also find it by having your patient bend their knee a little bit, and it's right where the crease of their hip is. So your textbook, and you can go ahead and relax. Your textbook answer is femoral neck, and then these are just some ways or some kind of cheat sheets to find where the femoral neck is. So I'm going to put the center right at the level of the femoral neck. Now I'm going to move my shield a little bit out of the way. If it's above the symphysis to the ASIS, then it's going to basically cover the pelvic inlet, which is where the ovaries are. So even though it's in the field, it's not going to cover any of our bony anatomy. So I actually want it in the fields for this picture. Now I'm going to have you roll your right leg in, just like we did for the femur. We want that rotation of the leg about 10 to 15 degrees in to show us a true AP of the hip. All right, 40 inches. I've got my marker. I'm going to put it on the bottom right side of the cassette so that I know it's definitely not in the anatomy. All right, hold your breath, don't breathe, expose, and you can breathe. Now I'm going to do the modified cleaves, which is the AP oblique hip, which is also called a frog leg. So now I'm going to have you bend your right knee and go ahead and let it fall open towards me. And this is going to give us our AP oblique. You're still going to center at the femoral neck. Sometimes when they bend their knee, they tend to shift a little bit, so you just make sure that you're still at the femoral neck. So I'm going to use my shield to locate the symphysis and the ASIS, find the midpoint between the two, and then 2 inches distal to that. And I'm still in a really good spot. She really didn't move her body too much during that. In your textbook, they'll talk about angling the collimator to match the long axis of the bone. If you do that, you can collimate in a little bit. It kind of depends on department protocol whether they do that angle or not, because whether you angle or not, the cassette does not angle. So it depends on your department protocol, but you might see techs do that. All right, so modified cleaves, hold your breath, don't move, and expose. You can go ahead and breathe. So this is the Daniellis-Miller method of the axiolateral hip. You might also hear this called a cross table hip or a trash can lateral in the clinic. So there's a lot of tube manipulation in this one. So I'm going to show you the tube manipulation first. There's a lot of factors that go into it. So the first thing I'm going to do is I'm going to move the pad and the patient all the way towards me.
I don't know. There's not a sheet, so
Okay.
I'm heavy.
No, you're good. All right. So she's all the way towards me. Then I'm going to move the table all the way this way towards the center of the class. From there, we're going to come on this side. The first thing I'm going to do with my tube is I'm going to angle it so that it's a horizontal beam. So now my beam is coming out this way, it's horizontal. I'm going to use the purple one to turn it all the way around this direction. So green first, pointed towards the front of the classroom, and then purple rotated around towards the back door. The reason I do it that way is because now the bulk of the equipment part of the machine is on this side. If you happen to turn it the other way, the bulk of the equipment side of the tube is going to be on that side, and it's going to get in our way. So the next step is I'm going to place my cassette. I have my cassette in a grid and in a cassette holder. I'm going to feel for the top of the crest, which is here, and I'm going to align the top of my cassette with the crest. You go and relax. So I'm keeping in mind where the femoral neck is, which I already located during my hip, right here at the crease. I'm going to make sure that the center of the cassette is at the femoral neck. The way to get there is to put the top of the cassette at the crest and then turn it to match the angle of the femoral neck. So now the femoral neck and my IR are going to be parallel. Now I'm going to align my tube so that the tube is also parallel. I'm going to go ahead and put my left marker on here while I can. So in this case, her left leg, this one, is the one affected. That's going to be the one closest to the cassette. So I like to bring my tube pretty close so that I can see if my tube and the IR are parallel. And I like to look at it from a couple different angles. So I like to look at it from here, and they look parallel. I also like to look at it from here because sometimes it looks really different. And then the last place I like to see it is right behind the cassette itself. Okay. So now that I've just got the alignment right, now I'm going to get the centering right. And in order to do that, I'm going to bring it down pretty low. And now I'm going to raise the unaffected leg out of the way using one of these foot holders. So now what I'm looking for is the femoral neck on the affected leg. And because I already aligned my table or my image receptor to the femoral neck, all I have to do now is align my tube to my image receptor. So you're still going to be going right at the crease of the leg. You're just viewing it from a different angle. So when you're centering this way, you're still looking for the crease of the leg, which is where the femoral neck is. When you're centering this way, you want to look at the entire thickness of the anatomy and then go towards the center. So I can actually move this up just a bit. It's really important that your tube and your image receptor are parallel. If they're not, you will get grid cutoff. You also want to make sure that you don't have any light on the wall like I have over there. That means that my beam is bigger than my cassette, and everything that's not on the cassette is wasted radiation. All right. And most of the time you're going to be doing this for trauma, so you're not going to do anything with the affected leg. You're just going to leave it as is. If it was not a trauma, then you would rotate the toes inward just like you did on the AP. All right. For this one, you can shield. Just going to throw the shield on top and just make sure that it's not in your shadow and it's not going to obscure any of the anatomy. You can also see if there's any light on your stand, that means it's also wasted radiation, so you just want to make sure that your stand is far enough out of the way that it's not capturing any of the beam. All right, and hold your breath. Don't move, don't breathe. Expose, and done.